length of life.
Well, unfortunately, the study doesn't look at that. I mean, I guess the problem with early sex would be the risk of STIs and all that, because if you're having sex much more earlier, you're doing it more riskier. You're not doing it in a monogamous relationship and things like that. We know for women that if they have, especially if they have multiple sexual partners at early on in life, it increases the risk of cervical cancer. But I mean, yeah.
So even though statement 1 and 2 is research,
yes,
but we do have people who are celibates,
yes,
and still they don't necessarily die early. So I don't know.
Yes. So the thing, though, unfortunately, when we do research like that, is that we control for confounding factors. Now, people who are celibate, they have other confounding factors. They have healthy lifestyle otherwise. They eat well, they eat good, the people that's proper celibate, they have other things that go for them. You understand what I'm trying to say? Now, we're just looking at sex only, because there'll be confounding factors there. You get what I'm trying to say, sir? Because celibate people, I mean, people that are fathers and all that go, monastery and all that. Yeah, reverend fathers and monastery. They eat well. They do other things. The stress levels are different from you, because celibate means that they don't have the stress of taking care of a family. So, but if you take a man who has a family and all the stress of the life of the family, and you take another man who has all the stress of the life of another family, so equal, yeah. And this one is having sex regularly, and that one is not having it regularly. This one is more likely, other confounding factors taken care of. That's what I mean. Yes, sir.
You need the mic.
Okay, thank you. It's just that, thank you, sir, for raising that point. It's something I've been thinking about, and maybe it's something that we need to find time to discuss, how people view research. Because when we say in research something like this, it doesn't mean that everybody. That's not what it means. It means if you take 100 people, this proportion is affected. It doesn't mean that everybody follows that. That is, and that's the only way you can do research. Because people will make arguments like, if the doctor says smoking is not good for you, and my grandfather smoked until he was 100 and it was okay. You understand what I mean? So it's just research looks at averages.
Thank you very much. I'll rush too quickly. I just wanted to, this is the most important slide in all that I've been talking about. So there's reduced risk of heart attack in people who have intercourse 2 times a week. Only 1% of heart attacks are related to sexual activity. So that's the first question, really. Except you already have an underlying problem there. Sex is a good thing.
Sorry.
Yes, sir.
We've heard of cases of people who perhaps maybe they are above 50, and because the activity of sexual urge or bringing there's erectile dysfunction, so they're having midlife crisis, and perhaps maybe they're using Viagra and those kind of things, and in the course of having that sexual intercourse, we've heard of people dying.
Yes.
So what's the
I'll get there, because the next thing is erectile dysfunction, and I'll get there, and I'll explain some of those things there. So there's this Duke study which I wanted to say that quantity is important for men, for women is more quality than quantity. And extra 4.5 years is important. Let's just quickly go. So this is erectile dysfunction. Erectile dysfunction used to be called impotence, and erectile dysfunction is the inability to attain and maintain an erection that is sufficient for satisfactory sexual performance, and it affects everything. And I've said this is the way we score erection. 1 is like tofu, like cheese, it's soft. 2 is like the peeled banana, moderate erectile dysfunction. Satisfactory or slightly suboptimal is the banana that is not peeled. Proper cucumber is what Doug, we use it.
You need to make this.
So, erectile dysfunction dysfunction is also common as we grow older. And we cannot tell you how much better because men generally tend to be ashamed that they don't go for help, so we don't know exactly. But we know that about averagely 150 million men in the world have erectile dysfunction. And that study in Cologne says that, it took an average of 30 to 80 years. They found that erectile dysfunction was averagely about 19%, but at the lower end, it was 2.3%, at the higher end, it was 53.4%. Now, some people will say that, oh, my erectile dysfunction is because of psychogenic problems. We know psychogenic problems can cause erectile dysfunction, but it's only about 10 to 20%. The rest of it are other causes. And I'll go through the causes because that is very key. And then I'll rush through the rest of it. So the commonest cause of erectile dysfunction are vascular causes. So for us to have an erection, it is dependent on two things. The arteries that take blood to the penis and the nerves that help with, nerves here, down here, that tell the nerves that release the nitric oxide. So the nerves release what we call nitric oxide that causes the arteries to engorge. The arteries get engorged with blood, and then the bulbar cavernosus, let me not forget, there's some constriction that stops the blood from going back, and then you have a standard erection. Now, vascular causes will be, and Dr. Petros took us on cardiovascular problems last time. Vascular causes is about 40%, and diabetes is 30%. So diabetes and vascular causes, which are very linked, account for 70% of erectile dysfunction. 70%. The rest of it are medications, trauma, neurological problems, endocrine problems, and the 1% is unknown, but so now psychogenic. I'll get there. Let me just rush through this. So, and that is where cardiovascular problems and diabetes is important. We know from research now that some people would have cardiovascular problems. That's the risk of having a heart attack and a stroke. But they don't show any signs. The first thing that goes is the erection goes. 3 to 5 years before you have any sign of heart or stroke, the erection has gone. And the penis is the barometer of your cardiovascular health. That's the barometer. Because 3 to 5 years before, that's what goes first. So that's why if anybody comes to me and say, I have erectile dysfunction, and it's not because they're taking drugs, they're drinking too much alcohol, the first thing is we check for diabetes, we check their blood pressure, we check their bloods, we check, do the normal thing you would do for someone that's coming with cardiovascular problems, because this is very key. So ED shares risk factors, erectile dysfunction, I'll just call it ED, shares risk factor for cardiovascular disease, lack of exercise, obesity, smoking, high cholesterol, hypertension, diabetes. So there's also hormonal things. Some people is because they have low testosterone levels, so hypogonadism, hypoprolactinemia, and thyroid disease, Cushing's disease. I'll rush through all of that. Sorry, the slides. Neurological problems also. People who've had strokes before because they affect nerves, Parkinson's disease, tumors, spinal cord injury, alcoholism, kidney failure, they can have erectile dysfunction. Drugs, that's another big one. Antihypertensives, some antihypertensives that help can also affect that. Some beta blockers, diuretics, some antidepressants, some antipsychotics, recreational drugs, cocaine and all that can affect erection. Anatomical problems. Some people, as we grow older, they develop a condition called Peyronie's disease. The penis just starts to curve because of plaques. And that's the way it looks, it curves that way. And that can cause erectile dysfunction. Also, people will have penile abnormalities or micropenis. And then psychogenic problems, and that's just about 10%. Psychogenic problems are usually, problems of sexual intimacy, lack of arousability, situational, partner issues. And I wanted to add the lack of money.
That should be first.
Lack of money. Because that's what you're thinking about. Can't cause, stress generally. It's not a big thing. It's usually more temporary rather than a permanent thing. And you can easily, and one of the things that helps us to know whether something is psychiatric illnesses also can cause it, alcoholism also can cause it. One of the things that helps us to know whether this is an organic cause, which is there's a reason for it, or psychogenic, is because people that have psychogenic causes is a sudden onset thing, and then when they still have early morning erections, because the erection, the machine is functioning, it's just the mind that is not functioning very well. So they will have early morning erection, or when they masturbate, they will have, because some people have what we call performance anxiety, and if there's a change in relationship or there's an issue or something like that, because you had problems once before, when you go the second time, okay, let me forgive me, it might be crude the way I'll say it. If, for instance, you're with your partner and things didn't go well, you just didn't get an erection or something like that, and the next maybe 2 days later you want to do it again, there's a bit of anxiety with it that I hope I'll get. And when you're anxious, then it affects your erection next time. So sometimes it's performance anxiety, and but usually those ones you have early morning erections, you'll be fine and all that. So those are usually temporary. And sometimes when people come with me and they've just changed partners, or someone whose maybe wife died or something and now has a new partner, when they have a new partner, they sometimes can have erectile dysfunction. And what I usually do personally as a doctor is that I give them a bit of Viagra. I say that go and use that, because once you get a good performance under your belt, the next time you're like,
Sorry, Dr. Kunle.
Yes.
You mentioned Viagra again. I listened to, there's a person who is a health doctor, sexual therapist, something,
Yes.
and was talking about, this particular young man who got married, and the wife said because of inactivity got him on Viagra.
The wife.
Yeah, the wife suggested for him to perform, and now he continued, but now the Viagra, it has become a problem. It has affected other health problem, and the man is dying, and the woman has left. So, what's the effect or the impact of this issue of Viagra and on the life and the health of the
And that's actually not true. Viagra, really truthfully, doesn't affect if you don't have any underlying cardiovascular problems. Viagra is generally very safe. It does have its own risk. Any chemical has its own risk. It does have risk of visual problems and things like that. But that's if you've been fine on it. It doesn't cause any long-term sequelae really.
It was originally developed as a cardiovascular.
It's a cardiovascular drug, and I'll tell you how Viagra was developed. They were doing a research. They were testing, and we still use it for other things, for primary pulmonary hypertension. They were testing Viagra as a drug for pulmonary hypertension, and when you're testing, you do cohorts, you blinded study. So maybe this side, they give them the proper product, which is Viagra. This side, they give them placebo. They just found out that this side guys, they were not coming back. What is going on? It's not like erection was getting there. So they then went back, because it was Pfizer. Pfizer then went back, and what is really going on? Oh, this thing causes vasodilation everywhere. Oh, then they developed it as for erectile dysfunction. So we still use for cardiac stuff. It doesn't have any real sequelae. Let people not tell you so. So first line is things like Viagra for treatment. Viagra, we have Cialis, Viagra, Levitra. All they do is improve the smooth muscle relaxation, and release of nitric oxide. There has to be arousal though. So I usually tell people that you still need to do all the foreplay thing to get the arousal. Unfortunately on the NHS, they will usually only give Viagra 4 tablets a month is what they will give. But Viagra is available over the counter now as sildenafil, and it's cheap. But as I said, if someone has erectile dysfunction, let's check first that there's no underlying cardiovascular problem. Time is almost up. Okay. A quick Viagra. Also, you can use vacuum devices. That's the next thing for erectile dysfunction. I'll run time. My time is up now. Other therapies, you can inject things into the penis that can cause an erection. Creams, some creams that can be used also. Penile prosthesis also. There's some herbal supplements that some people have used. They are unlicensed. They might have adverse effects. The research for them is not very great, but herbal supplements. Okay, so my final thoughts.
Thank you, sir. I think I'm in the midst of my brothers here, so I can talk freely.
You're also being recorded.
It's public information.
You should note.
Just to share, back 2015, 2016, I think it's a testimony I shared here on varicocele veins and the effect on erectile dysfunction, because I noticed you didn't talk about that. Maybe if you want to, that's something I suffered from varicocele veins, and that leads as well to low sperm count, poor erectile dysfunction and all. Miraculously, I was healed on that and had the baby. But I think that's when the doctor, the urologist spoke to me about it. There was also, I can't remember the statistics, but he said that's also something that hinders a lot of men in terms of your sexual performance and all. So I don't know if you may want to add some light on that.
Yeah. So thank you. It's part of the anatomical things that I didn't mention, or I just wrote other penile things. And varicocele is just like engorged veins in the scrotum and penis area. The biggest thing actually is more fertility than even sexual function. Fertility is a big one. It can cause subfertility, but not full infertility, but subfertility. So it's bigger than even erectile dysfunction, but it can. Those are penile abnormalities. But I mean, it's more fertility, but it's engorged veins, and when you lift, the sac has a lot of veins. You can sometimes see it visible. When you lift the sac up, you get, but varicoceles generally tend to be also that you've had them for a while. Not you don't go on to develop them. It's not like as you grow older you're developing varicoceles. Really, it's more that you had them. Yes, sir.
When does the urge slow down? What age?
There's no age, though. There's no particular age that the urge slows down. As you grow older, the urge reduces because your testosterone, as I said, does fall a little bit. So I wouldn't say this is a particular age. It's different. Even women, their menopause is, some 42, some 55. So it's a very individual thing.
The struggle continues.
So in this day and age of DNA sequencing and advanced genetics, is there any light at the end of the tunnel that one day there will be cure for ED and all these issues, prostrate that men have, by just sequencing their DNA?
That's a very, very good and big question. Yes, we hope that with DNA sequencing, that prostate cancer cure is down the line somewhere. ED, it's a difficult one because there will be tailored treatments. There will be some sort of tailored treatments because if there are things, especially for cancer care, cancer treatment, definitely down the line, we'll get more cancer treatment coming through.
But
Yes.
mom was there.
Your mom must die of something, yeah. Mom must die of something. So final thoughts.
That's the concept.
My final thought is your willy working. If your willy is not working, your heart may be in trouble. Erectile dysfunction precedes cardiovascular event by 3 to 5 years. So if you have erectile problems, please get it checked. Please get checked because it precedes heart attacks and strokes. They can check it. Just because the penis is heading in the wrong direction doesn't mean that the heart has to follow. It can and should prevent it from doing so. And the way to a man's heart is through his penis. And that is my final slide. Thank you very much. Sorry, brother, before brother Daniel, Dr. Daniel wanted to speak to us. Want to do it now? Yes.
Let me just ask a question. My question is, I hope we are going to have this slide again.
Oh yeah, yes, slides are already with brother Shola. You can share it.
Good morning, brothers. As you can see, there's a lot we have learned, there's a lot we have heard, and there's a lot that we didn't know before now. So, in light of this, myself and Doc, and also and the three of us, we are conducting a research. As you know, I'm an academician, so that's all I do, is this research. And he is our chief. So, in this, we want to understand our African men's perspective to this, and also the other areas by which things can be improved on for us regarding the information we have had and all of that. So the bottom line is that we are going to be distributing a questionnaire to each and every one of you outside here so that you feel comfortable to fill it and don't think someone is looking at what you're writing. Yeah? So we'll send out a questionnaire. Please do get back to us so that we can proceed with that empirical study on this topic. So we'll appreciate that.
No, I think you mentioned it. It's just to urge you to do this because the plan that we have, there's very little in terms of research, in terms of African men's health in the UK specifically. So going forward, we intend to collect as much information and data as possible, present it in a reasonable way, and push that up the tree for the policymakers and everything to see if there are areas in which they can make an impact. So that's our vision. Our vision is to collect data because we can't just go to them and say, oh, these are the things that we are talking about. But if you go with evidence that we have looked at this and this is the evidence we have, then we put ourselves in a stronger position. So please do help us fill up those